Okay, go ahead.
Hello, everyone, and I'm very pleased today to invite our speaker, Professor Arjun. This is WFNS Radiosurgery webinar series, and today's topic is of a great general interest, that is the radiosurgery after resection of the brain metastasis. The question is no longer whether to give postoperative radiosurgery. The difficult question is who needs it, when do they need it, and how much brain are we willing to irradiate to achieve this control. To introduce our speaker, I invite my co-chair, Professor Selçuk Peker.
Thank you, Manjul. Today we have a very important person in radiosurgery world. Dr. Arjun Sahgal is our guest today, and he is the Professor of Radiation Oncology in University of Toronto, and he's also working in Sunnybrook Health Science Center in Toronto, Canada. He is a global leader in stereotactic radiosurgery, and he's very experienced with different subjects of it, mostly the metastatic lesions in the brain and the spine tumors. Also, he is very experienced with the primary tumors, the treatment of the radiation treatment of the primary tumors, and he has enormous number of papers, a lot of international guidelines, which is very important, and his age index is 86, and he trained a lot of fellows, and he still continues to train fellows from all over the world. So he has a lot of additions to the literature, and he is the past co-president, co-chairperson of the Spine Tumor Knowledge Forum, and he was also the past president of the ISRS, and he is the founding member of the Electa Unity MR-Linac Consortium, and he is advocating the use of adaptive MR-Linac treatment for glioblastoma and reported in the United trial. And we are very happy to have him here, and he is going to talk on the post-operative irradiation of the surgical beds with the metastases. So please, we are ready to listen to you.
Okay, everyone. Well, thank you very much. It's a real great pleasure for me to lecture today. And Manjul, you can see my slides. Everything's all good?
No, sir, we are not able to see right now.
You
need to start sharing.
Share again. Okay.
Yes, they are
perfect. Excellent. Okay, it's a great pleasure for me to talk to you about postoperative cavity radiation, but we're also going to kind of evolve into just further topics as we go along, and kind of give you a bit of a holistic understanding of where the field is at. Just my disclosures. So surgery in terms of intention. So where are we right now? Well, for large brain metastases, more than 3 to 4 centimeters that are symptomatic, we would advocate for surgical resection. Smaller lesions, but symptomatic brain metastases, for example, toxic edema, there's herniation, neurologic deficit, better to take it out. Obstructive or pending hydrocephalus, indication. Radio-resistant tumors, still sarcoma, but more significantly GI primaries like colon cancer, if they're solitary, probably better to take them out irrespective of size. Acute hemorrhagic mets that are symptomatic, or if you need relief of mass effect, then we would operate. And sometimes you still need it for tissue diagnosis, but that's changing also based on liquid biopsies and as we get more proficient at ctDNA. But what about after radiation, after surgery? So traditionally, after surgery, you see the cerebellar metastases, you have a postoperative cavity, we would give whole brain radiation. And now it has evolved to giving stereotactic radiation and treating only the surgical bed. And the establishment of the value of postoperative radiation really came from trials from many years ago, including the Patchell study. But the evolution in terms of where the evidence is at, I think we have to understand it in the context of radiosurgery. So whole brain radiation versus radiosurgery for postoperative surgical beds. And this was the subject of the NCCTG CEC3 trial, which randomized patients to whole brain radiation versus radiosurgery. And if you look at the distribution of the patients, a randomized study, about 100 patients in both arms, good balanced group in terms of size. Majority of patients had a gross total resection, en bloc or piecemeal. There's some nuances there in terms of what that could mean, but basically gross total resection. And the majority of patients had one brain metastases. And when we looked at cognition, because this was really the issue in terms of why the field was moving away from whole brain radiation, you saw better or improvement in cognitive deterioration-free survival with radiosurgery as opposed to whole brain. But when you start looking at the details, and in particular the surgical bed control, what you see is that whole brain radiation actually fared better. And at 12 months, it was 80% versus 60%. And many of us, when these data came out, were really quite confused at this because this was not necessarily our experience. And the rate of leptomeningeal disease dissemination was quite low in both arms. But this was a global randomized study, and this was important, and it established radiosurgery as a treatment of choice. But what about the surgical bed control? Because most of us are looking at this more so than cognitive-free, deterioration-free survival. And that's where, when you look at the details, and some of these big cooperative trials are a challenge, and it's a challenge for them to ensure the quality of the read and the reporting, because they get a report or they're in a community center without necessarily neuroradiology and say tumor progression when it's radiation effect. So they went back and looked at the patterns of failure and did a central review of the images. And really what they found was that radiosurgery was no longer associated with significantly lower rates of local control than whole brain radiation, because they did a central review, okay? And resection cavities greater than 3 centimeters still had a higher rate of local failure, and large target volumes were associated with a greater risk of local failure. So no surprise, but at least this takes out that mystery of what happened, because it didn't make sense. And they're still in the process of publishing this paper, but it has been presented. So one of the questions that resurged with kind of radiosurgery was, do you need it? Can you still do surgery alone? Because the surgical techniques have gotten so much better than in the old days from Patchell. And there was this data and retrospective data from the MD Anderson claiming 90% tumor control in their hands, as opposed to most places saying 50 to 60%, And so there was a randomized study that was done. So the MD Anderson did a randomized study of observation versus radiosurgery. And what did they find? Well, they found, look, once you start doing a prospective, proper trial with proper outcomes, not retrospective, you're getting the same rates of failure as everybody else. So there's no magic here, okay? 50%, usually we quote about a 50% rate of failure at 1 year with surgery alone. With radiation, you have an improvement, and with radiosurgery, we saw that improvement, okay? So again, took out some of that, myth that maybe if you have surgery in one place versus another, you'll do better. It's a biology, and it's just a function of the limitations of surgery. So what do we learn from the study? Well, if your tumor is really quite small, and this was preoperative diameter, you had about the same rates. You had better control with radiosurgery still, but the gain wasn't as impressive as when you looked at the larger tumors. In the intermediate, there was no difference, but these are small numbers. But when you looked at more than 3.5 centimeters, radiosurgery really had a better outcome than observation. So again, this preoperative diameter, which is what they used, was a significant predictor of local failure. But at the end of the day, you need adjuvant radiation. And I think that's the message. So what about salvage? And this was a very interesting and still very difficult study for me to completely understand after all these years. I've read it a number of times. And so this was a Japanese study, and it's important in the sense that what they randomized patients to was whole brain radiation versus salvage therapy. And if they had residual, they were treated. If they didn't, and gross total resection, they could be observed, okay? So they actually had 44 patients who had no radiosurgery, but the majority of them had radiosurgery for subtotal resection. So ultimately, they did find that this grade 2 to 4 cognitive dysfunction after 3 months was only 7.8% in the radiosurgery arm and better than whole brain radiation arm. Okay, so it wasn't the primary endpoint, but it did provide some cognitive information in terms of the impact of whole brain radiation, 16% versus 8%. But if you looked at local failure, it's about the same on both arms. So again, lower than expected rates. Why? And these questions keep coming up in these literature, and you have to understand the details, and it's hard to kind of parse this out. Now, one of the last kind of trial that I'll mention and why this is important was this is the Australian study that was melanoma specific. And this is one of the only studies that is actually specific to one histology and randomized patients following either radiosurgery or surgery, whole brain radiation versus observation, okay? And what they observed here was that distant failure was no different with the use of whole brain radiation. And why I bring this up to your attention is that this is a traditional kind of benefit of whole brain radiation that we've learned from all the other studies was that distant brain failure is reduced. But it may not necessarily be true for all patients, in particular radio-resistant disease. So in melanoma, you really question what is the value at all of whole brain radiation, right? Sometimes you have to do it just because there's so many, and you just have to bridge, or there's lots of bleeding metastases everywhere, and you just got to get control over the brain, but it might be short-term, okay? But this is an important study because it challenged that dogma once again. Okay, so why have the control rates been poor generally? And part of the reason is the majority of these studies use single fraction radiosurgery dosing. And as the tumors are larger, we start to underdose. And we do that to respect the rate of radiation necrosis. And this dates back all the way to the Shaw data. And cavities are larger by nature. They're more irregular. They don't fit into a diameter. And these studies allow for relatively low doses of single fraction radiosurgery, and hence control rates are not necessarily better than whole brain radiation. And if you look at the kind of biologic equivalent of the dosing, once you get to 12 gray in one or 14, 15 gray in one, it's probably no different than 30 gray in 10 fractions. So you're not necessarily getting that benefit of tumor control as a result of the underdosing that has to take place. So this is where fractionated radiosurgery or hypofractionated radiosurgery comes into play in delivering treatment in 3 or 5 fractions. And why fractionate? Because it's safer on the normal tissue due to repair. There's some technical safety if you do it daily, whereby the hotspot's not in exactly the same place, and there's some dosimetric uncertainties that are blurred. They may be more effective due to reoxygenation and redistribution, and you can safely escalate the total dose to achieve an equivalent biologic effective dose than what you would have given in single fraction if it was smaller, okay? There may be some repopulation and repair between fractions, really not an issue for hypofractionation. That's more for 6-7 weeks of radiation. Now, there may be some changes in the tumor dimensions, and that is an interesting area. And there may be some newer biologic effects associated with high doses of single fraction that we may not be getting, but we're not seeing that. It looks like the magic window in terms of the dose per fraction is probably 5 gray or more, not less than 5 gray per fraction. Okay, so what's my experience? Well, we've been doing this for many years. When I came back from San Francisco as a fellow, I started doing cavity right away. I mean, I wasn't going to do whole brain radiation. And we did 5 fractions because it was relatively new in Canada, and in particular in Toronto, and it was challenging a dogma. And that dogma had been here for a very long time. So I was cautious. We did 5 fractions, mainly because we have a large experience of 20 gray and 5 fractions for whole brain, that I always know where that 20 gray isodose line is, and we know what to do. So we're mainly treating with 30 gray and 5 fractions. We had a good experience. Our local control rate was 85%, symptomatic radiation necrosis rate 6%. So pretty good, and certainly better than the randomized studies whereby you had single fraction low dose data. And this has become pretty much our standard. Now, we put our data in together with a multi-center cohort study with centers from Germany and around the US and Australia. And ultimately, we saw the same thing. Okay, so median follow-up for a year, we got good local control by 85% in 1 year, 70% at 3 years, relatively good radiation necrosis rates, and everything is looking pretty standard. And these are bigger numbers because you always have to test your data with others, but still retrospective. And for larger tumors versus smaller, really no major difference here in terms of survival probability, but larger ones may be a little bit worse. But overall, we're pretty happy. Nothing surprising. But we do need randomized data, and so we always have to put our money where our mouth is. And this is an important study because this is a randomized phase 2 of hypofractionated stereotactic radiation for cavities versus whole brain radiation. So 35 gray and 7 fractions versus 30 gray and 10 fractions. And this is randomized study. Ultimately, 56 patients were randomized, okay? Diameter is pretty standard, okay, 2.6 centimeters. A number of, they allowed for untreated and treated, but the majority didn't necessarily have a gross total resection or had a gross total resection, but overall pretty standard, okay, in terms of your baseline characteristics, okay? From the point of view of control, we're starting to see, again, similar rates of control with whole brain radiation versus hypofractionated stereotactic radiation. And your intracranial progression-free survival, you know, favors the whole brain radiation because, again, you have less distant failures, okay? That's when you put it together. But your local control rate was about the same. Now, 35 gray and 7 fractions is pretty conservative, you know, in terms of dosing. So you just may not be giving enough, but still showing the safety of hypofractionated radiation. So again, it's interesting when we put these data together, and we have to understand what are the optimal hypofractionated radiation dosing, and there are other trials looking at this as well. Okay, so let's talk about the challenges. And one of the challenges is actually contouring the postoperative surgical bed, and there was a lot of variation that was happening. So this was just an example where you have resection of the tumor, you've got your MRI postoperatively. A lot of times you don't have a preoperative MRI because the patient's gone into surgery quickly. You draw your surgical cavity, it's difficult. Here, there's a different example in the cerebellum. There's not much. What do you treat, you know, in terms of your postoperative bed? And when you look at a number of centers that we put together to draw this, look at the variation that was happening between everybody. There's a lot of, you know, uncertainty in the contouring of what's a postoperative surgical bed. And that's why we did a consensus guideline. Okay, so we had a number of specialists, both radiation oncologists, both neurosurgery or neurosurgeons, and also gamma knife and non-gamma knife users. And we put it together and we came up with some recommendations. Okay, but ultimately you want to take the postoperative bed. We made some recommendations about tumors in contact with the dura. The clinical target volume should take about a 5 to 10 millimeter along the bone flap, so taking that dural margin, okay? And what I do is where if it's in contact with the sinus, I take about 5 millimeters of the sinus, just because that's an area where there can be microscopic residual disease. So we've come up with some guidelines to help standardize contouring. And so it's interesting. So many people kind of come up with different rationales, and I'll bring you this example here. So this was a paper that was published by William Beaumont on their experience, and you see this 16 gray being delivered to this surgical bed, and they had this failure here along the dural margin, okay? And they argued, and maybe it's this, maybe it's that, and we said, well, hey, listen, maybe you didn't treat the dural margin, and that's your problem. So we wrote a letter to the editor saying, look, you know, you have to include that dural margin because you do see those dural failures, okay? And that's why one of the tips and tricks is always to try and get your preoperative imaging and understand where that dural contact was, because that guides my clinical target volume. So here in this posterior fossa met, surgery was done, it's all resected, it looks beautiful. You get your CT, your MRI. What do you treat? Well, I'm going to treat that dural margin, but I'm going to fuse the preoperative MRI, and that guides where I take it, and also look at my CT and my bone flap. So all of those things are determining where I'm going to be treating that dural contact to reduce the risk of failure. But I'm not going intraparenchymally because everything is resolved in that area. There's no kind of surgical cavity within the cerebellar tissue there. So these are just things that we do in these challenging cases. Now, there is some clinical validation of the contouring guidelines. This is from San Francisco, where they looked at their postoperative cavities and where there was preoperative dural contact. And what they found was that there are some failures that can happen if they don't take that 5 to 10 millimeters or so of the dural contact. So a little bit of data to say, you know what, taking that extension along that meningeal margin could potentially have reduced failure. So it's always good to have some of these type of data. And these guidelines are also acknowledged in the NCCN. And this was many years ago. And this has become pretty much a standard of care. Okay, so let's talk about a little bit about dynamics, because we did learn a little bit about dynamics when we brought in the Elekta Unity. So this is a 1.5 Tesla MR Linac. And we did a lot of work in this, and we do a lot of work mainly in glioblastoma. But in the beginning, we did do some work on surgical beds because we thought there could be some variation. And so we had our preoperative or simulation MRI with gadolinium. And then we did a gadolinium enhanced image at fraction 3. But otherwise, you can't give gadolinium every day. So what we found was between the simulation and the third fraction, that's where you could compare GAD to GAD. There is variation that we're seeing. There's changes in volume that are occurring. And when you look at our FLAIR imaging, which you can get standardly for 1 to 5 fractions, again, there's variation. So these cavities are dynamic. Usually within a 2 millimeter planning target volume, you encompass this variation nicely, but it's just food for thought. So trying getting it done as quickly as possible is likely a good thing to avoid the issues of dynamics. Now, what's the downside of surgery? Well, one of the downsides of surgery that we've learned over the years is the risk of leptomeningeal dissemination. Some would occur anyway, others are iatrogenic. And that iatrogenic leptomeningeal seeding, approaches anywhere in the literature between 10 to 30%, okay? So we looked at our experience of patients who were treated with intact tumors versus surgical beds, okay? And the rate of leptomeningeal disease was in the intact group about 10% at 2 years and 24% after surgery and hypofractionated radiation. So hypofractionated radiation doesn't necessarily mitigate that risk, it can just occur. And you can get classic LMD, nodular LMD, focal classic and focal nodular. There's all these different descriptions. But at the end of the day, the classic is the one where we use whole brain radiation. If you have focal leptomeningeal disease, we use radiosurgery. And this was just a cumulative incidence over time. So you have to be careful, use surgery wisely, and we have to have some strategies to mitigate this risk. Now why it's so important was because once you cause leptomeningeal disease, patients ultimately die, right? And our 1-year survival is 15%. Some of the patients who were on a targeted agent actually had a lower incidence. So these targeted agents may be working towards treating that microscopic disease just so they're so effective in the brain. But ultimately, it's a major issue. And this is why the evolution of preoperative radiation versus post-op has evolved, and it's being tested in randomized studies. And what we're seeing is similar rates of local failure, okay? Radiation necrosis may be lower, but that LMD rate may be coming down. So treat it preoperatively, cut it out. At least if there's dissemination of cells, they're treated cells. And that's the rationale. And I love doing it. It's just a matter of coordination sometimes and the urgency of surgery at sometimes that we just don't get it. But I think it is the future, and there's definitely indications. Now, it evolved with single fraction. And the evolution of single fraction was really still to treat a very low dose, because assuming these tumors are large. So there has been some comparative data of 15 and 1 versus 24 and 3 with multifraction. And you are seeing less failure, okay? Otherwise similar rates, but less failure, and that failure rate may be lower because you're giving a better dose than you would have otherwise with single fraction at a lower dose. So again, I think we're seeing more and more hypofraction radiation is becoming the standard of care. Now, there's a multi-institutional database that's been reported. Again, you know, we'll wait and see for the outcomes, but ultimately, we're seeing, you know, nothing new in terms of what the factors are associated with local recurrence, okay? And in this analysis, we see that gross total resection is better, maybe fractionated versus single fraction, but the fractionated cohort, if you look at the numbers, the majority of them are still treated with single fraction. So they're low numbers, but there's a little bit of data. So how do you dose? And that's one of the questions that comes to me all the time, especially in the beginning. You know, what's the dose limit on the normal brain tissue? Like, you know, for single fraction, we've had V10, V12s for years, but we never really had anything for 5 fractions or 3 fractions, which is really the norm. And I used to just look at it and just say, look, I think it looks a bit too big. Let's go from 30 down to 27.5 or 35 to 30. We didn't have the numbers. So we actually did a pretty big analysis on our intact and cavities to look at rates of symptomatic radiation necrosis and what were the dosimetric predictors. Now, what's important here is that the cavities actually had a lower rate of symptomatic radiation necrosis versus the intact. And why? Because look at the volumes. The volumes are much bigger for the cavity than the intacts, okay? Your dosing, you know, were similar, but your volume. So what this paper did for me was help me address this question of when you have an intact 1 centimeter lesion in the brain and you get massive radiation necrosis. Why? Your V10 was 1 cc or 3 cc's, whatever. It shouldn't have happened because it's the interplay between the factors within the tumor and the normal tissue that are contributing to radiation necrosis, not just the normal tissue dose. And that's what was important in this paper that I think we were able to show. And it was bothering me for many years, you know, what that issue was. Now we found a number of dosimetric parameters that were important, and then we looked at it in our multivariable analysis and what were the predictors in the intact cohort. So that's really where we're able to see this volume of normal brain minus that gets exposed to 30 gray. If it's less than 10.5 cc's, very low rates. If it's more than 10.5 cc's, it's higher rates of radiation necrosis. A similar parameter was found by the St. Louis group, and that's a bit rare when we see coordination of a dosimetric parameter. So we're happy with that, and it was significant on the multivariate analysis. So we use this parameter, but it's not the only parameter. And HITECH put it together in terms of single fraction, 3 fractions. This is our 5 fraction data, and came up with some numbers, okay, in terms of how to guide your dosing, all right? And we use these numbers for us as well. So if we can't meet the metric, you know, we have different strategies, and one is to reduce the total dose that we prescribe. So how do we dose at Sunnybrook? These are our numbers. So we use a variety. We have single fraction. Again, we don't do it as much, only in intact brain mets that are small, but we use a lot of 3 fractions and 5 fractions, and we have different constraints, but we have our hard constraint, which is the V18 on 3 fraction and the 30 and 5 fractions, but we look at multiple parameters. So we've kind of put it all together, and these are our numbers that we look at. So one of the interesting things also, as I've learned over time and done LINAC and Gamma Knife, is this issue of heterogeneity, okay? And if you look at a Gamma Knife, it really is very heterogeneous. You see 47 gray, sharp dose gradients. If I try to give 25 gray on a LINAC, it's completely cold, okay? And it's never seemed to matter, and it didn't matter on small brain metastases. The predictor was your minimal peripheral dose, right? It's been very consistent over the years. Didn't matter the heterogeneity, and why, right? You know, when you think about it. So this is why this paper was really quite interesting for me. So what they did was they took out radiosurgical failures, okay, either LINAC or Gamma Knife treated, and they looked at the actual kind of sequencing, and they found different enrichments of expression of genes between LINAC-based failures and gamma knife failures. Okay, and I thought this was fascinating because what it explains to me is that there may be a difference in the biology associated with a heterogeneous dose distribution versus a homogeneous dose distribution, and that's what I was trying to kind of understand over these years. So this led us to our study. So we have a study now saying, you know, for these larger metastases that don't meet our metrics, what do? I don't want to necessarily underdose. I want to give my 30 gray and 5 fractions. So what we did was we combined the two now. This is called GK Live. This is an ongoing trial at Sunnybrook. We are doing 24 gray and 4 fractions of LINAC, and then we give a gap. Okay, we wait 2 to 3 weeks, then give a 6 gray and 1 boost. So we're giving the 30 gray and 5. We're just doing it in a different way, and we're combining potentially this mixture of biologic effects. Okay, so you do your 24 and 4. This was about 4 centimeters. We waited 2 weeks. It came down to about 3.5 centimeters. Give my 6 gray and 1. Here's the patient 6 months later on Tagrisso. Beautiful, complete response. Save this patient surgery. Save this patient a 20% risk of dissemination, right? And this is where we're moving to. And this also brings rise to this different concept and where we are in the field right now, which is called adaptive radiotherapy, or what I say response-based radiation treatments. And this, again, this is the future. So we have this patient here. This was a melanoma metastasis, very clear, close to another treated one, high risk for radiation necrosis. So I'm going to zap it. 2 weeks later, look at the response, give another fraction. 2 weeks later, really smaller, 1 more fraction. Here, there's nothing left, so I stopped. So I didn't even give my intended dose. And this is where we're heading. We have to understand, is this safe? Are we going to see late failures? And this is why, you know, we need to do this under trial. But we've been doing this for most of us that have been doing radiosurgery, and in particular in gamma knife, because of stage radiosurgery and the initial experience from Japan and Cleveland Clinic, and some places that were doing these staged procedures. So hitting it 3 weeks later, hitting it again for these larger metastases with a frame and going through all that. This is not new, you know, but I never really did it because I knew how to do hypofractionated radiation anyway. Why would I do staged? Well, I started doing this for radiosurgery failures, okay? And we reported our first report of staged radiosurgery as a means to salvage failures following stereotactic radiosurgery. And I devised this regimen of 884. So we give 8 gray, and I did this because this is a threshold where we think the biology starts to change in terms of biologic effect. And that's where it kind of came to me. And then 2 weeks later, 8 gray, 2 weeks later, 4 gray, because I'm respecting the fact that I have to decrease my overall total dose, but I'm trying to get that biologic effect. And this was a radiosurgery failure. So this is high risk, right in the brainstem. And I did the math, and we came up with this regimen. So we're able to publish our data. We look at the changes in terms of this volume between fraction 1 and 2. We are seeing reductions, but between 2 and 3, there's a lot more reduction. So it kind of gives you this rationale as to why you wouldn't do 2 stage fractions, do a few. In this case, we did 3. Again, typically 2 weeks apart. This is the guy 5 years later, okay? Typically, if I did a repeat single fraction radiosurgery, the risk of radiation necrosis 20 to 30%. If I did hypofractionated, it's about 10%. In ours, we're seeing about 7% symptomatic. So we think it's better. But it brings together new principles of reirradiation. So your principle is, on the second time, you decrease your total biologic effective dose, increase the number of fractions, do both, and now adapt with the gap, okay? And so we're happy with this, and we're moving it forward. And these are just some of the data from our 89 salvage stage cases. Again, we're seeing, you know, pretty good rates of local control. These are rates of local failure here. And again, our grade 3 radiation necrosis under 10% as time moves out. So we're pretty happy, okay? And there was a mixture of patients with either previous single fraction or hypofractionated radiation where we use this regimen. So I'll show you this case here where we hit this tumor. 2 days later, we had a repeat MRI, and look how small it went, right? And you say, oh my God, what did you give? That's amazing, that response. Well, here, what I actually gave was no radiation. I gave osimertinib. And this is where we're in a different era, and we're in the era of CNS penetrant drugs. And how do we manage this with radiation? So I'll show you this patient, patient with large brain metastases and posterior fossa. This patient was 90 years old, okay? Had another lesion here, smaller. There are some other scattered smaller ones as well. So we said, well, this is a big one. And the medical oncologist already started osimertinib, okay? So it came and referred to us like 20 days later. We're like, okay, we repeat the MRI. We're not seeing a major response here. We're seeing it's better here, but these smaller lesions were gone. So at that point, I said, look, we should treat you. We want to avoid this still large. We don't want to operate, and we're going to zap this larger one. We're going to leave the smaller one. So we gave, in this case, 5 gray, and we interspersed it 2 weeks apart with the osimertinib, holding the osimertinib 2 days before and after. So here we gave stage radiosurgery. You see volume reductions that are happening. Okay, 4 months later, we're seeing this kind of response. This is the top one with drug alone, and overall, we're pretty happy. She's done pretty well. Okay, and this is where we're trying to start to bring in radiosurgery with the drugs and use them together synergistically. So there are some data to guide, who still needs treatment with radiosurgery, because we weren't sure in the beginning. So this is the Turbo study that suggested that, most patients benefit, even if you're more than 1 centimeter or less than 1 centimeter from radiosurgery plus the TKI. Now, not all these patients were 3rd generation, okay? And for EGFR, this is probably true, but for ALK, I don't treat very much. We just give the ALK inhibitors as long as they're next generation because they work so well. But this is good data suggesting synergistic and better response, but use the radiosurgery. This is the combined analysis of the Canadian and the Australian studies looking at osimertinib versus SRS plus osimertinib. And what you see here in the forest plot is the tumors that are more than 15 millimeters had a benefit, okay? And the overall volume or burden of disease also suggested a benefit, but I look at the individual tumors, okay? So again, larger tumors may benefit from radiosurgery. Smaller tumors you could potentially observe, okay, and treat drug alone. But it's not the whole story, and you have to look at the type of mutation. And this is the IGNITE study, which is now published in JTO, which shows you your classic exon 19 do pretty good, okay? Maybe irrespective of size. But your atypical, your L858R or your atypical mutations, those are failing at a higher rate. So it's a combination of understanding the type of mutation, but also the size. And so for these atypical or L858s, I'll do radiosurgery up front, but for the exon 19s, I'm much more careful. And still for larger ones or critical locations, I'll treat up front. So we need a randomized study. So these are data from TATA that were presented at ASCO, which is really about either upfront or delayed radiosurgery. Now, these patients, there was a mixture of patients in terms of 1st generation, 2nd generation, 3rd generation TKI. So it muddies the water, okay? But ultimately, about 44% received radiosurgery, 54% received whole brain radiation in those patients who were treated upfront, okay? Median follow-up 27%. And you're seeing the cumulative incidence of intracranial progression at 1 year, pretty good, okay? 8% versus 25% with upfront, okay? So maybe a little bit more data suggesting a benefit to upfront, but we have to wait for the publication. We have to understand what's happening. But at least we have some randomized data that are coming in. And again, we need to understand this better. And this brings us to Pulsar. And this is, I think, where we're going with CNS active drugs. Okay, and I'm a believer. We're starting a trial, but this is good. And so the way they did it, their main fractionation were 3 radiosurgery fractions every other day, 2 to 3 week break, and then they do the last 2 every other day. They saw good rates of local control with tumors greater than 2 centimeters, But when they sequenced it with a CNS active drug, you saw very low rates of local failure as opposed to those that didn't have a CNS active drug. And this is real, and low rates of radiation necrosis. So we have to understand this better because it's an opportunity for us in radiosurgery. And part of the reason why we really need to understand this and understand the rates of radiation necrosis, because some of these agents are really increasing the rate of radiation necrosis. And this was a letter from Sloan Kettering showing that with these ADCs and breast cancer, your rates of symptomatic radiation necrosis are really quite high. Now, this may be really driven by TDM1 as opposed to newer agents. And we have a little bit of data that are going to show that. But they considered concurrent being 7 days before or 21 days after radiosurgery. And that's a long break for patients. You don't want that, right? If you have to treat it. And you don't want them off their drug for that long. And that's why there's an opportunity with pulsar or sequenced radiosurgery with these drugs. Now, if you do cause radiation necrosis, we have ISRS guidelines to help you. So we have an algorithm, and there's Avastin now. So we have a treatment. So it allows us to take a bit more risk in patients who need it. So I'm going to show you a recent case of mine. So this patient had a tumor right in motor, okay? So what and was going to get TDXD, okay? So I said, give the first shot at TDXD, she had liver mets, everything, get it in there. And also I want to treat the brain, and the patient was not necessarily symptomatic. Surgeons didn't want to go in, and I would rather, have that shrink, right? Rather than treat up front. We're right in motor. So I gave 6 gray times 2, okay? Another cycle of TDXD, smaller, gave another 6 gray because I'm trying to get to 30 gray in 5 fractions. Here's another cycle, smaller again, another cycle, a little bit smaller again, and we finished the treatment, okay? And this is where we're going. So if you can deliver response-based radiation, we may reduce the risk of radiation necrosis, okay? And still achieve tumor control. And this patient neurologically was perfectly intact, but it's too early. This is another patient, 5 gray times 6 with immunotherapy. I gave 5 gray. This was like close to a previous radiation. And again, by cycle 5, I stopped. So I didn't even give the last fraction. So it's a real new era in terms of where we're going. But someone like this, 34 Mets and everything like that, unless they have an ALK mutation or an EGFR mutation or getting some kind of CNS active drug or maybe HER2 positive with TDXD, we're going to treat this patient, right? And especially if they're melanoma, we don't want to give whole brain radiation, renal cell. And this is, again, another important area in terms of our future, which is multiple brain metastases. And the question is how to treat them. So many people would give hippocampal avoidance whole brain radiation. Again, I think it's not unreasonable, but if you can do radiosurgery, you should. But what are the data? And how do you do it? And this is where, we had to do a little bit of work because the community felt that treating radiosurgery for multiple brain metastases was like giving whole brain radiation. So we showed the hippocampal dose for patients with 10 to 30 brain mets, showing it's still far lower than hippocampal avoidance. No surprise, but we wrote a paper and we showed it based on our actual clinical cases, okay? So you can never spare the hippocampal better than with radiosurgery. Now, what are the data? So we have data for up to 10 Mets for radiosurgery from Yamamoto. And now we have data for up to 20 Mets. Okay, median was 15 and 13. Radiosurgery versus hippocampal avoidance whole brain radiation, better cognitive function. Now, what was also important here is they allowed for hypofractionated radiation for tumors greater than 3 centimeters. And that shows you this evolution in trial design as well. So how do I do it? Well, I use a gamma knife, so I'm just showing you what I do. But we developed our technique to treat multiple brain mets, and we call this SPARE. So this is distributed treatment. So if you have 20 brain mets, we treat up to 60 minutes a day. So you may treat 4 or 5 per day, and you get it done over several days. Okay. And why is this good? Because you're treating your tumors without the effects of fractionation in terms of a negative effect, but the positive effect is on that normal brain integral dose. So you're essentially fractionating that normal brain dose. And that's why it's like night and day when I treat someone with 40 brain mets, no dexamethasone, coming and going, like, and Seljuk, you'll remember that, when we put a frame on and treat 50 brain mets, the patient's not doing very well the next day, okay? The recovery is not there. This is night and day for me, okay? We love it. and we believe we're optimizing the therapeutic ratio, but there's a lot of appointments, and you have to respect the time from your MRI. So if you exceed 7 days, we repeat the MRI, we replan, and we're essentially adapting on the tumors that we haven't treated. However, our data are suggesting probably 14 days is okay. So this leads us to our Sunnybrook in-house trial, 5 to 50 brain mets treated with radiosurgery alone. Our median is looking like about 18. And we did an observational phase 2 study with neurocognitive outcomes as the first primary endpoint. And these data will be presented shortly. We're under embargo, so we can't announce anything until the press release, but it's coming. So stay tuned, because this is the first prospective data that have looked at more than 20. Okay, so this is up to 50 brain metastases. Okay, and half the cohort had more than 20. So we're excited about this. Okay, so I want to end with a little bit of tips and tricks, okay, in terms of dose distributions and planning. So this is a patient, getting 6 gray in one part of a stage. That's irrelevant. What you have to do is you have to look at, we do allow 1 millimeter, half a millimeter PTV axially, but craniocaudally 1 millimeter. Okay, that's our practice based on our own data of the system and the mask and how it functions. But if you look at your higher dose line, be mindful of it. Keep it out of your normal brain tissue. So push it in. You can have your prescription dose kind of covering your PTV, but keep your higher doses within the GTV, and that's good practice. The other issue is bridge dosing. Okay, so this is a single fraction. These are 220 gray in one fraction. I look at the 14. I try and break the 14, push the system, break your 14. Okay, and then you're good to go. But it's not just about the 10 and the 12. I look at the 14 for single fraction, and that's your bridge dosing. When you start talking about 3 fractions or 5 fractions, certainly I look at where I can break the bridge. Okay, so in a 27 and 3, this is my 8 gray. I really want to break it, but it's too close together. I can't. You got to be mindful of your other targets. Here, in this case, I could break the 8 gray, and I did. And that 8 gray times 3 is therapeutic. I really like breaking at the 7, but you certainly want to break at the 8. So always look at your bridge doses, all right, and how you're planning, because that can contribute to radiation necrosis. Pushing the gradients, again, there's a number of ways that you can do this with your treatment planners. Look at your organs at risk, push the gradient where you have to, know where you can be generous on the gradient and where you can't, adjacent to an organ at risk. You really want to push that gradient higher, and you can do it, okay? So in conclusion, I think postoperative cavity radiosurgery and hypofractionated radiation, well-established standards of care. Whole brain radiation provides local control for surgical beds. The tumor is out, right? So that's not necessarily the overall rationale. It does reduce distant brain failure, maybe not for melanoma or certain radio-resistant histologies, but it's associated with worse neurocognition, quality of life, similar survival. So the standard of care is to go focal. Smaller cavities, single fraction versus hypofractionated radiation, I think is fine. Larger cavities should be hypofractionated. I hypofractionated everything. Pre-op is a way to mitigate the risk of radiation necrosis, leptomeningeal disease, and the issue of contouring variation. This pulse radiosurgery to intact or cavities is becoming more and more of our standard when there's a CNS active drug, but we're going to be doing it as a trial and take advantage of adaptive radiation. Okay, and this issue of pulsing may ultimately change the way we dose, and that's what's exciting, because not everybody needs that therapeutic dose, and that radio responsiveness, we can actually see it in real time and adjust how we do things, and that's where the overall field of radiation oncology is moving regardless. With that, I want to thank Manjul and Selchuk for inviting me, and happy to take any questions. Thank you.
Thank you, Chief. I think we neurosurgeons like to say that AVM is a dynamic disease, but I believe now the metastasis is the most dynamic disease, and the treatments are getting more and more dynamic with all these options available. So before Dr. Selchuk starts his questions, what's the time interval between the surgery and the radiosurgery in your cases?
Yeah, so that's a good question. I mean, I didn't really show that because there's not a lot of good data, but there's data which was not necessarily big numbers, but there's some meta-analysis, 2 to 3 weeks. That's what we use. And, there's some data about 20 days or 18 days is better than shorter. If it's shorter, it may not be as good in terms of radiation necrosis or control. So we use 2 to 3 weeks. Basically, let the incision heal, let everything settle down. And this is the issue of the cavity as well. Let that cavity settle down in terms of the dynamics. And then I plan at 2 weeks and I treat at 3.
Do you sometimes find it difficult to differentiate between all these hemostatic agents like Surgicel or gel foam and some tumor margin? And if you have that situation, what do you do in those ones?
So that's where I use the T1 pre. So we don't only get a T1 with GAD and flare, but the T1 pre really does help. I think the Surgicel and everything like that is always a problem. But understanding where your preoperative tumor is, that's why we always fuse the preoperative, and then understanding where the hemorrhage is. And like these hemorrhagic mets are difficult. And that's where, in some of those situations where there's a lot of still hemorrhage and we don't really know if there's a tumor still there, we deal a lot with melanoma here, right? That, in fact, at that point, I give, equivalent of whole brain radiation of 20 gray and 5 fractions, which we know is safe. It's not going to cause necrosis. I'm treating microscopic disease in the hemorrhage because we know that there's microscopic disease in the blood. And then I bring them back 3 weeks later, re-image them, and if I can see the actual tumor nodule, then I boost it. So we have to start to think differently about how we do things, and in particular in these hard to discern surgical beds when they're hemorrhagic.
Dr. Selzuk?
Thank you so much. It was a very nice presentation, and we are very happy to hear these very important subjects from you. And I have some small questions for you. Do you use alternate day irradiation for the surgical bed irradiation in your department?
No, we just do it daily. I don't really know if it makes a difference. There are some situations where we have learned in, say, prostate, that it reduces the risk of acute and maybe even late. We never knew the late complication, but the acute we knew was better, but there is some data. But then there's some conflicting data in lung SBRT that's showing that, daily is better. So we don't know. My issue is avoid the issue of missing. So these dynamics of the surgical bed is what we want to mitigate, get it done, and just do daily. And 3 fractions is pretty nice and convenient. We do 5 because we've been doing it forever. And but it's also a good rationale for single fraction because, if you do it close to, you don't have to deal with dynamics. And there's a lot of good data for single fraction for smaller cavities. So no issue from my point of view.
Yes. The other question, you showed an intact metastasis and said that 0.5 millimeter or 1 millimeter margin you may use for this. Do you use margin for the surgical bed? Because the surgical bed is so large sometimes. So I think margin may become with very huge volume for the radiation.
Well, the thing here is that planning target volume margins are there to account for uncertainty. So we always do it. So on a LINAC, when we do a surgical bed, we use 2 millimeters. On the Gamma Knife, when we do a mask, we use a 0.5 millimeter axially, 1 millimeter craniocaudally. And that's based on our analysis of what's happening during the patients in the mask. It's not 0, but it's pretty damn good, and it does depend on where you put your threshold also for repositioning. Now, we do this for safety because it's not just about the patient motion, it's all these other factors of uncertainty. So yes, it can get larger, but that's where we use our dose constraints. And in cavity, and again, this was something we don't know enough yet about, what is that optimal dose? Do you need to give, so for example, I give 30 gray and 5 fractions for intact or cavities, but there's no dose response data for a cavity yet. Okay, so is 25 and 5 enough? Is 27.5 and 5 enough? Do you need 30 and 5? We don't know. The control rates seem to be pretty good either way. Okay, so we don't have a dose escalation understanding in surgical beds as we do for intact metastases. Okay, and that's why I feel comfortable if we don't meet the metric going down to 27.5 and 5. Or 27 and 3 going to 24 in 3, because that's still therapeutic, okay? What we don't want to do is go below that, because that's where you're starting to get into whole brain dosing, right? And equivalent. So 12 in 1 or 15 in 1. If you could give 18 in 1 to a cavity, I think give it. You know, it's good treatment. But the concept of the fractionation is to at least get up on the total dose, but also maybe mitigate the risk of the necrosis, because again, it's, you know, it's less in cavities, but it's problematic.
Sometimes we see very large cavities after surgery. In your department, do you have any cutoff point to treat the patient with gamma knife and to send the patient for LINAC? Is there any cutoff for volume?
Yeah, so we're very comfortable with 5 fractions, irrespective of the volume. But sometimes we'll go to 25 and 5, which is pretty safe. You know, even 5 to 6 centimeters, you're fine. The issue is if the surgical cavity is that big, I'd wait it out, you know, and give another 2 weeks, re-image, let it contract. It just hasn't contracted enough. But I wouldn't want to wait more than 4 weeks, you know, and that's you know, I think that's you're starting to push it. But remember, you got a 50% local control, or at least maybe a 30% local control rate for larger sizes with surgery alone, and you got a bit of time. So let it contract and then go for it. Now, we use LINAC predominantly for surgical beds because our intact is reserved for gamma knife and functional and you know, benign tumors. That the LINAC is so good, and we have our experience. And I like the homogeneity of the dose distribution, because you don't have to have such heterogeneous steep dose gradients in a surgical bed, and you may not want it, you know. But when we have an intact and a surgical bed, sure, I'll put it on our gamma knife and use the same instrument. You know, we're rates of control are the same.
Next question. What do you think about the systemic treatment for the surgical bed instead of irradiation? If there is no residual tumor there, to wait for radiation and continue with, I mean, follow the patient with the systemic treatment, is it an option?
It's a great question. It's one that we just don't have data. Now, the way I approach this is this: if they're ALK positive, forget about it. Don't give any radiation. They're going to get lorlatinib or you know, 2nd, 3rd generation ALK inhibitors. You know, you're fine. EGFR, we don't know. You know, probably with the exon 19, if they're going to get drug, I wait. You know, honestly, there's variation of practice even in my own group, because the surgical bed recurrences are so nasty. You know, typically, you know, it's not like an intact tumor, and so we kind of, you know, we kind of see what the overall burden is and the size, but we're more likely to treat than not, even in EGFR. And if they're HER2, like these are the main ones, right? That we'll definitely treat. Now, immunotherapy, melanoma dual agent, I treat always, pretty much, even if they're going to get dual agent, because you don't see those types of response rates that you are with HER2 positive on an agent like TDXD or the ALK EGFR inhibitors, or some of these newer generation ones that have response rates of 80% in the brain. Like it's phenomenal. So it's really just the ALKs. Everything else I pretty much treat.
Thank you. Thank you so much. Majul, please go on.
One of our attendees today, Dr. Dogu Sihan, he has asked an interesting question. So if somebody is operating on a metastasis with all these intraoperative adjuncts, so what are your thoughts about the intracavitary radiotherapy after resection of metastasis for the progression-free survival, local control, and rate of LMD?
Yeah, well, so look, so, you know, now we have this gametol data, right? You know, and it's showing very good. I mean, it's good. I mean, I'm sure it's fine. We don't really have the experience with it, but we'll get the final publication. I don't think it's out yet. I think they just presented it, if I recall correctly. And but they're showing no failures. I mean, you know, that, like, you just may have to wait a bit, but look, it looks pretty promising. The whole issue is, you know, and this is where, you know, your experience and understanding is better on the neurosurgical side. Like, are you introducing additional factors for infection or issue? I don't know, but but it's pretty good. You know, we haven't really seen it or anything really help get glioblastoma. Like there was a recent intraoperative radiotherapy boost for glioblastoma, totally negative for dose escalation. But in surgery, you know, if you look back at the days even of Gliadel, you know, and they had using for metastases, the actual failure rates were really low. It's just, you just want to avoid other complications in the brain. And that, you know, we leave to your judgment as to the safety, but it looks pretty good from the data.
I think, Chief, the main problem in all this is that we are actually not confident about the true microscopic extent of the disease. And as a surgeon, once we operate on a metastasis, once I was in residency, the concept was to go around the tumor because it's a well encapsulated one, so you can remove it easily compared to a glab. But then came the concept of that supramarginal resection, and they started telling whenever it's possible, go to around 5 millimeter to 10 millimeter more. And if you remove this, probably you have removed the complete metastasis and you do not need anything. So if somebody comes to you telling that I have done a supramarginal resection, I have done a 1 centimeter extra brain removal in the right frontal lobe, it was a totally non-eloquent one. So would you like to wait in that thing, or would you like to still suggest a postoperative SRS in those patients?
Yeah, look, you know, we have a lot of variability in the concept of supramarginal, you know, and how sure you are, and you know what, if you did it and it was high risk, or it was small, then sure, you could wait. I mean, you could wait anyway. You know, it's still like it's a relative risk reduction, absolute reduction of local failure of 20%. In higher risk patients, let's say, where it's probably more relevant is in radiosurgery failures. If you did a supramarginal, then I wouldn't expose the patient to a risk of more radiation. So that's where it is. I think the practice of supramarginal is really quite limited. But even in the MD Anderson study, you know, en bloc versus piecemeal didn't matter, right? You know, it wasn't a predictive factor. So everyone tends to benefit from radiosurgery to some degree or the other. And you know, what we don't talk about and where there's not a lot of good data is just the issue of what happens to failures, because you know they do tend to be much more difficult to control.
In your observation, where do you find all these failures more, in supratentorial compartment or infratentorial? You told one thing about the genetic ones, the supratent and the infratent. Do you make some difference in your approach according to that?
No, not really. I mean, I think the main thing on the infratentorial is that they tend to be higher risk for leptomeningeal dissemination. So I would say, you know, we're probably a little bit more generous on the meningeal margin in those cases, as opposed to supratentorial, but everything else is pretty much the same, I think.
Well, it has been a really interesting and good discussion, and I'm interested to look at your new data about that. It's coming for the 5 and the 50, so that's going to probably close the final chapter of WBRT versus SRS until the new front of targeted therapies versus SRS would open.
Yeah.
Thank you so much, Professor Sahgal. This was an amazing day and such a pertinent topic with so much good discussion. Thank you so much.
Thank you so much.
And
Thank
this
you.
will soon be on the WFNS channel, so all can see it who are not able to attend it because of any other reason. Thank you, Professor Sahgal.
Bye-bye,
Professor
Arjun.
Sahgal.
Thank you.
Bye-bye.
Thank you.
See you all.
Bye-bye.
See you.